So, Assalamu alaikum wa rahmatullahi ta'ala wa barakat. My name is Dr. Faiza Nasir. I am an obstetrician gynecologist and I'm also the gynecologist at Coast General Teaching and Research Center Hospital. Happy to be here today at this Kamp's fifth scientific conference and to do this skill station on gynecological cancer. And I think our emphasis will be on cervical cancer because it is one of the pandemic right now. About every hour we lose almost 3 women to cervical cancer because of late presentation. And just good to go to what the WHO says, the 90-70-30. In 2030, we hope to have 90% of women in the reproductive age group screened for cervical cancer, 70% of those women to have undergone HPV vaccination, and HPV vaccination is available in our facilities and in schools for school-going kids 10 years old for free. So please take this opportunity to have our kids vaccinated. That's the primary prevention that we talk about, yeah? Screening is actually secondary prevention. So we need to start with the primary prevention, that is actually taking our girls, and for those who can afford, take your boys for the HPV vaccination. The one that is available for free is Gardasil. That covers HPV strain 7, 11, 16 and 18. So it has a bigger range. It's actually a quadrivalent, yeah? So it also covers the anogenital cancers for the men. So please take an opportunity to have your family, your sisters, your siblings, your kids vaccinated. And then out of those who will have been screened, 90% to have access treatment of either the precancerous lesion or early cancerous lesion. We are nowhere to get to this, but I think with all our efforts, we'll be able to achieve, if not 90, 70, 90, but closer to this. So on cancer screening, the Kenyan guidelines talk about HPV testing. That should be the first line. Yeah, but HPV testing, just recently is when now the country, the government is rolling it for free. So HPV testing is available for free in public facilities. Where I work at Coast General, we do our screening, the first contact screening on Thursdays. So and it's done by a very qualified nurse with support of the gynecologist. So we do HPV testing for free. And this is for women in age 30 years. So anybody more than 30 years of age can go for HPV screening. But if you're HIV positive, you screen at the first contact. So even if you're 25 years old, you need to be screened at that time. So HPV screening is what we now advocate. And once you do a HPV testing, I think I can show you some. So there are different methods of, this is self-testing. So nowadays people can do it at the comfort of their houses. So this is offered in most of the private labs. They offer this, so they give you this with instructions of how to do it. Once you've done it, then you can send it to the lab. But for the public facilities, we do it for them. And whatever we collect, we then put it in this liquid preparation. So it's offered for free. So once you do a HPV testing, if it is negative, then you come back for screening after 5 years. So you start off, it's very sensitive. Yeah. But if it's a HIV positive patient, their screening time is a bit shorter. It's 3 years. 3 years, yeah. But if it is positive, yeah, then you need to move to another step. So once you do, and most of the time the kit is able to test for HPV 16 and 18, and these are the culprit for, these are the precursor for squamous cell carcinoma, especially the type 16. Yeah. So once it's positive, then now you are referred to a specialized clinic for further evaluation. So in centers where they're not able to do HPV, then they do cytology. When you talk of cytology is where now you do our pap smears. But pap smears have their own limitations, you know. It's skills is required to do it, yeah? And then you need a lab to do it, yeah? So in our center, it has a cost, yeah, because it has to go to the lab. It's the cheapest. We charge 300, but even that 300 is still a lot for a common person. So we do it on Thursday. So once a pap smear is done, and if the results are negative, repeat after 3 years. If they are positive, then now you come now to the specialized clinic that we normally have it on a Friday. That's our colposcopy clinic. So for those who cannot do cytology and HPV, then there's another pathway called visual inspection with acetic acid. And this is done mostly in the peripheral facilities where they use vinegar. And so vinegar, what it does... Okay, so they use vinegar to actually, so they prepare the patient, be able to visualize the cervix, and you should be able to visualize the squama-columnar junction, and then they actually apply vinegar, which is called acetic acid, over strength of 3 to 5%, and then you'll see an aceto-white lesion. That means it's to do with coagulations of proteins. So once it picks up, then you say that's a positive aceto-white lesion. I think I have a, yeah, this is, okay. So if it's a VIR positive, you'll see an aceto-white lesion. So once you get that, then these are patients who are then referred to a specialized clinic. And for us, it's a Friday colposcopy clinic. Okay, so that's part of the screening algorithm that we have in our country. Those who are able to do HPV, that's the start. If you're not, then you can do the VIR. For those who can do the pap smear, yes, but it has its own limitation as well. So once the patients have been screened and they've been found to have an abnormal HPV test, 16 and 18 positive or a VIR positive, then they are referred now to our unit where we do now colposcopy. So this is a colposcope. So it's just a magnification. So for us, we are lucky because this helps us to teach and also for the patient to see what we do. Yeah. So once you've keyed in the patient's data, sorry. So once you've keyed in the patient's biodata of the patient, age, parity, then you now go to examining the patient. Yeah. So examining the patient start by inspection. Yeah. So once you have positioned the patient well, you're able to visualize the cervix. Let me just see if I can. Sorry, this has to calm down. You need to visualize the cervix. So, sorry, the ergonomics here because the bed is different. So once you visualize the cervix, that's the first step. After you visualize the cervix, you need to see the squama-columnar junction. So this is an area where most of the transformation process goes on. So then you have to put normal saline. So you start by doing normal saline. So you clean the area with normal saline, and then you change the light to green light. So the green light, so are you able to see our cervix? Yep, so that's our cervix. So then you use normal saline. Normal saline on green light the vessels become more visible. And there's a grading system of the vessels. So once you see the vessels, you talk about them. Are they fine? Are they punctations? So there's a grading system. After you've done that, then you put in your vinegar. Yeah, that is now the acetic acid. Okay. So some people put Lugol's iodine to increase the sensitivity so that you can get more clarity. But vinegar can, for those who cannot afford, because it's a bit expensive, Lugol's, then you don't need to. Vinegar will be able to, just like what they were doing for VIA, will be able to see the lesion. It's a white lesion. Once you do that, then you proceed with a punch biopsy. And this is done under just Vaboken. Yeah. So we just talk to the patient. You don't need to send the patient to theater. NHIF doesn't pay for this. So once you'll be able to see the lesion, then you go in and the patient is able to see what you're doing. You get your specimen, dip it in formalin, and you send the specimen to the lab. So sometimes there might be some bit of oozing. We normally pack the area. In our center, we have something called Moncel solution. This is prepared by our pharmacy. Zinc, ferrous sulfate, so we actually apply there. And we give procedure instructions to the patient. Yeah, so we tell the patient, you might get some discharge. The return date is normally after 2 weeks, and by that time when they come back, we get results. So this is now a tissue diagnosis. You remember cytology is fluid, yeah? So once you get your results, it may tell you it's a normal finding, maybe just cervicitis. It may tell you CN1. So if it's CN1, you follow the patient. You don't need to be aggressive on them because the lesions can regress. If it's CN1, 2 or 3, these are patients who require now additional treatment, yeah? And that is what we call LIP. We take them for LIP. And if it's a CN3, we still do LIP. But sometimes it can tell you carcinoma in situ. So you need to now do additional imaging on those patients and probably stage them for now surgery. That is probably either if it's a young patient who still wants to fertility preservation, yeah, so we can only remove that part that is abnormal. So we can do conization, or we can do what is called trachelectomy and still leave the uterus in situ. And she's able to conceive. But if she ever gets pregnant, then we put a stitch so that we can, yeah, so we'll just remove the part that is affected. And then if she ever gets pregnant, we'll put a stitch so that she doesn't get the miscarriages. So I think I'll leave it at that and allow any questions. Please feel free to go through this. Yes.
Is there a chance that you can miss and check a normal tissue?
So I can't say yes or no, but most of the time, because you do these are patients who are referred from a positive cytology, positive HPV. So this is not the primary screening that you need to know. This is now after the HPV, the first screening. So we are always very strict to actually repeat to make sure that sometimes even they don't get, they say CN1 and from us we get a CN2. So there is a chance that you can miss, but it's very difficult because we aggressively look for it because somebody comes with a VIA positive HPV test. Yeah, but sometimes VIA, it could be positive, but it could be a CN1 lesion. And CN1 lesions normally regress. So you can come and don't even see it. Yeah, but then if they were abnormal vessels, that's where we pick our yeah, and yeah.
5 minutes change over. 5 minutes change over.
Survive. Okay. I think yes, so we've started doing that in our center. Screening has been able to reduce the cervical cancer cases almost by 50%. Yeah, but we still have a long way to go. We still have women coming in late. Yeah, and that is why we need to keep advocating for screening and screening and screening. So we have like for Mombasa, I can speak for Mombasa, every sub-county has an RH coordinator. And then we have the overall, what do you call, RH coordinator. So every sub-county has a... Okay, so we do outreaches. So we do outreaches to the communities. We do that, yes, yeah. So we do outreaches linking with community healthcare workers. So when we go for outreach, we get a positive VIA, then they're either sent to a sub-county hospital or they come directly to Coast General. Yeah. Yes, yes, you're right, yeah. Yeah. Oh, yeah, so I think it's to do with cost-cutting issue. But if you are able to, some people do this in theater, yeah. But we see now the hassle of taking a patient to theater, yeah. So we can give lignocaine to reduce the pain, but most of the time patients cooperate. I think maybe because it's a nature that allows it. But I agree, we should be giving some local anesthesia. Yeah. An obvious lesion, yeah. Yeah. I agree, yeah, we should, yeah. Now, sometimes we assume that they're not in pain, but I think it's important to do that. So I'd make sure that they're at a more relaxed environment. Yeah, I agree, yeah. Every Friday. Every Friday. So Thursday is our screening day. Ideally, in good center, screening should be daily. People should just be able to walk in and have, but because of we are resource constrained, we have the same nurse doing Monday clinic, Tuesday clinic, but in good center. But when you come in on a Monday, we will still screen you. But for us, screening day is Thursday. You come in, we'll have a pap smear, you'll have a HPV, and then from there is when we get our pool of patients for our Friday screening, yeah. So self-taking has its, you need to be able, so this is the one that is self. So what you do is you have to teach the patient. So what they do is they insert until they reach this level. Yeah, it has to go in. And once it's in there, then you push in and you rotate. So you can miss out, yeah. But even with this self-testing, sometimes we do it for our patients who come with it. I said, I want it done, yeah. Then you rotate, and then after that, you cover it. So you pull it back, and then you cover. Yeah, sorry, yeah, so this is our cervix. So it has to go into the vagina, and then once you're in, you do this, and then you rotate. Yeah. So you rotate. Once you've done 3 times, you push it back, and you cover, and you transport. Yeah, 3 times. This one, but for our center, this is what we use. And then we use the brush. Okay. So we use a brush, yeah, and then we dip it inside. Yes, we disconnect. So I need to show you one that you can disconnect. But there's one that you can disconnect and you put it in. Yeah, there's that. 3 to 5 times.
Time is up.
Okay.
We can move to the next
We need to
session.
take photos, please.
We move to the next session of your choice. You have 20 minutes in your next session. Let's move.
Oh, group photo.
The team that was here.
You clap for your presenters as you're going away.
Thank you so much. You can just move over.
Listen, you know, so many stations, you can just
Let's maintain silence.
some more.
Let's maintain
So as you explain,
silence.
1, 2. This one is for online, eh?
Let's move. We should all be in our second session. Diabetic foot examination. People to move to the diabetic foot examination. Those who are interested. You guys.
So, Assalamu alaikum. How are you?
Let's also
Don't mind as I'm doing this. There are guys listening somewhere. So we are just welcoming them also to this session. My name is Harrison Gitonga. I work with the Kenya Red Cross. And here we are doing mass casualty incident, MCI, mass casualty incidents. Could somebody tell me when you talk about mass casualty, what are we talking about? Nazungumzia nini? Mass casualty incidents. Ni wagonjwa kama wangapi wanafaa iwe mass? Kama wangapi? Numbers? 100? 100 plus? Now, mass casualty, we are not talking about mass on trauma only. Though here we are dealing with trauma, but we're not talking on mass casualties, trauma only. Mass casualty could be even a simple cholera case. When influx of patients come from one area, more than 10 actually, it classifies to be a mass casualty incidence. Sawa. So have you ever seen this? Mshaiona hii? Hamjaiona? You've never seen this, eh? It looks new. Sindio? Now, this is what we use when you are triaging patients. Triaging is sorting patients as per their injuries. So, triage is a French word that means doing the most amount of good to the most amount of people that we can have. So mostly in a mass casualty incidents, we will do a practical session for a group here. You'll go, then you'll come and manage a mass casualty incidents. Now, there are different patients that you can get in an incident. Even when they're presented in hospital, mostly you'll get the less injured people are the ones who will start coming to the hospital first. We are all of us in hospital setup. Yeah, we are pre-hospital, before it's the hospital. Now we see all these things outside. So when you get to, when patients are presented there, you're also supposed to do your own triaging based on how they're coming. Because Kenya, we don't have a very, very well elaborate system whereby the patients can move systematically from the scene to the hospital. Because the elaborate system is, even when patients are coming in, the facility must be notified of the kind of patient going to each hospitals. So Kenya unajua wakitokea tu mara moja, probox zitabeba, tuk-tuk zitabeba, mwenye pikipiki, mwenye kwa lift na personal car watafika. So all of them will be flooded mostly at which hospital? Coast General Hospital, sindio? Because other hospitals don't take, ama what happens? Oh, you do? So what happens? When it's presented to one hospital, like which hospital? For trees, you will take. So why don't people take patients to other hospitals? Really? Because of what? Cost friendly, eh? The money factor. So wengine hawasaidiwi, si ndio? Yeah. Airport, yes. So whatever we are doing, we should actually be practicing. We should actually put systems in place in our facilities for how we can manage mass casualty incidents. Now this tag, let me orientate you to what this tag is all about. This is called a triage tag. So we tag this one according to the kind of patients that you can have. Kulingana na wale wagonjwa vile watakuwa wako. Now here hapa tuko na colors ngapi? 4. You didn't see the white? Okay, yeah. Let's concentrate with the 4 colors, eh? Yeah, let's concentrate with the 4 colors. Now we have green, we have yellow, we have red, and we have the black ones. So what these colors are all about are condition of our patients. So we tag this on patients that you get. So, we say that the minor injuries, the walking wounded, wale wa green, those who have bruises, they are just involved or they're in shock. Sawa, those who need psychological support, wametoka tu kwa case, but they're actually okay. They can stay without care even up to the evening, ndio waanze kumanajiwa, but they're actually okay. So we tag them green. If you look at these tags, zinakunjika hapa. So you see, So if you're patient, then we have the yellows, So if a patient is in the green, umeona u patient kule anataka na kwa green, so you tag them green, unamwekea hivyo. Sawa, You can either tie it anywhere, either on the neck or something. Naifunga, so itakuwa ni identification tag of patient. So he's on the green zone. So then the yellow ni wale, yes please. Sija tag. For example, these are patients, ndio? Nimekuja nimewekewa yangu. Nimeshtuka tu, nimetoka kwa accident naangalia tu. I have no injury, mimi nimeshtuka tu. So I'll be tagged green. No, as in the last color is green. I'm coming to that. Now the next patient has a fracture on the arm. Sawa, So we'll do what? We can remove the green one. Inabaki yellow. Tunampatia huyo patient. Sawa, You continue like that. If it's the red, you tag the same. If you check there's no pulse, there's no nothing. Now, in a mass casualty incident, sometimes we don't commit resources to cases that you think might not survive. And when the resource is scarce, let's say, for example, you are the only person and there are 60 patients. So utajiweka mahali ukifanya CPR kweli? So you'll take the whole time there and the patient might not even survive. And then you lose all these massive bleeding cases, ndio? So you prioritize according to the injuries. Now the red, the yellow, tumesema ni wale ambao wako na injuries that can wait for care. They still need care, but they can wait for the care. Let's say they can be delayed somehow. Maybe they want to go to X-ray to be checked. The physio should come afterwards. They should be done POP baadaye, so they can actually wait. Then the red ones are those patients that you think they are very critical. Delay of care will actually move them to the black zone. The black is the dead people, the diseased. So hapa ni kama gani? Give me an example of the red areas that you think these ones are very critical. They need to be attended. Head injuries, protruding bleeding, what else? Ingine ni kama gani? Which kind of injury? Severe burns, nimesikia kitu kingine ukimetoka huko. Polytrauma, yes. Amputees. So these are the cases that you know they're in the red zones. They need actually to be done. Now, hapa tuko na tags. In a critical system sometimes, for example, what we did at Westgate kama Red Cross, tulikuwa na kama chandarua with the colors ambazo ziko hapa. So, and these colors have to be arranged the way they are, from green to yellow to red to black. So you put, because sometimes a patient can progress to these different groups. You can have a patient in the green, then suddenly they start convulsing. So you'll want to move them to maybe the red zones. It means they have a head injury. So you want to place them there because they need urgent care. So the colors have to be like that. Sometimes somebody can be here, then they progress to yellow, then they progress to the red zone. Sawa. So you place them like that. Then the resources could actually be more committed on the red zones. Though huku pia tutawacha hivi, we must put some people to manage them. Sindio? Any question to that point? So sometimes naweza kuwa na chandarua za hizo color, chandarua ya red, ya yellow, ya green. So as patient, for example, in hospital, as they come in, umezieka pale. One person has to identify them. Huyu mweke hapa. Huyu amekuja na tuk-tuk, waeke pale. Huyu mwingine mweke pale. So you are actually triaging, and that's the most important thing. Then when we have a mass casualty incidents, maybe we will want to offload all the workstations in our facilities. Mara nyingi what nafikiria kwamba the critical thing is managing the patient. But even relatives can be critical. The media can be critical. If you don't handle the media well, they'll actually sell you negatively. Kama media umeachiwa shughulikiwe na soja pale kwa gate, awasukume, wafukuze, wafanye nini, one of them will come and take a shot ya wewe mahali umechoka, wajipangusa, unajipaka damu, na hiyo ndo ataipeleka kwa. So maybe you will want somebody periodically, maybe after an hour. There's another training called Hospital Incident Command System. Is a control of when there's an emergency within the facility. So huyu ni yule mtu atakuja, let's say the senior most person in the facility. Kazi yake itakuwa ni kuchukua data, then anakuja kwa media periodically, maybe after every 1 hour. Anakuja na brief, in the last 1 hour, we've received this number of patients, we've managed this number of patients, this has been discharged, this one has been sent to the ward, we have this in theater, we have this, we have this. So that the media can have something. Then you give them something, a plea, for example, we need blood, mostly, so we can have people coming in. So at least you're keeping the media busy. So if you don't give them something, you make them angry, they'll come and get the negative and spread it to the news, because negative sells better. Yeah. Then the relatives. Sometimes relatives come in, unawachia soja. Then soja akiwa pale wataanza kusukumana. Then usikie soja ametandikwa mangumi, ameletwa kama patient pia yeye. That can happen, sindio? So we actually want also to put somebody there to collect data. Maybe official registration could also come in. As they get data, they come. Psychosocial support to open also somewhere, whereby if you want to give information to a patient is deceased, na mtu amekuja kumulizia, you give the details. Sometimes relatives come, lots of them in a facility, and maybe there are only 10 patients, but you'll get like 60 people looking for 60 people that only 10 that you have. So you also need to give them prompt information so that you can control them. So if you don't, it will be another nightmare outside there. Sawa. So with that, I'll want to break you into 2 groups. We do a scenario here. So you'll identify the kind of patient. Or anybody with a question? Anybody with a question on mass casualty incidents? So this is just a systematical way of how to identify patients as they come according to their injuries. We triage them. Sawa. Let's break into 3 groups. If time allows, we'll see. Now we shall have a scenario here. Yes? We shall have a scenario here. So I'll want to break, let's say for example, from there to here, this will be one group. Sawa? The lady on phone will be in another group, all the way to here. Yes, so let's break. Oh, you want to be in that group. And this will be in one group. Sawa? So we'll have this group. Kindly this group, let's move there. So when you come, we'll want you to control the scenario that we shall see. Sawa? Haya. Haya, wale wengine tumbaki. Haya. Now, this is what we'll do. We will put these dummies down there. Sawa? So, I'll want you to make it as chaotic as possible. As chaotic as possible, eh? Hai. Mamake huyu yuko wapi? Mamake nani? Mama mtoto amchukue. That's your baby, he's not breathing. Mtoto hapumui huyo. Hapumui. Haya, this can be somebody's brother, weko hapo chini. Haya, then I want some of you also to be injured, because in a mass casualty incident, when you get there, you could get the sick and the non-sick together. So it is actually you to identify who's sick and who is not. Sawa? Even when they are presented in a hospital, takuja matatu nzima, wawili ndio wagonjwa, wengine wanapiga nduru peke yake. Sawa? Haya. So let's have, what else can we have? I want somebody wakija, akwe weak. Weka hii mikono hapo. These are also full patients. Only the injuries depict what kind of patient they are. Sawa? Just put them there. Kando kando. You see, si huyo ni patients tofauti hao. Hao patient tofauti. Ni relative labda. It could be a Gaza scenario thing. Now, I want you to own up the injured. Mtu wangu amevunjika, amekatika, na mwingine amechomeka. Sawa? Then I want also somebody else, as they come, mtu anaweza hata anguka mwingine. So make it as chaotic as possible as they come in. So we want to see how they'll do. Nyinyi nyote. Nyote, you are one team. Sawa? It sells better. Sasa vile nishaeleza wale kuhusu red ni nini. So they have to identify which ones are the red ni. Kuna hao wengine wanafanya tu scenario vile iko, wanajaribu ku manage tu kusort. Maana we expect them waanze kuita waseme wale watu wanaumia njoo hapa. Waanze kuwasort. Haya, sawa? Haya. So let me talk to these guys. Hi, this is what we'll do. I'll want you to tag the patients, to put the patient. Now we don't have enough tags, Hatukona tags nyingi. So you'll get the patients in corners. Muniambie hapa ni red, hapa ni green, hapa ni yellow, sawa? Based on how you will see pale. Sawa? So I'll call you when you're ready. You can come in sasa. Njoni. Come in. Ingeni. You go in. Go and assist. Nakwambia baada hii session wale wote wanakuja hapa kujua kwa nini watu wanalia. Wale wengine wanataka kufanya scenario mbili. Immediately. Don't just place them where they're supposed to be. That's the patience. Guys, kuna skill stations zingine. Mgonjwa daktari ameleta shida sana. Haya, sawa. Haya daktari, meisha. Haya. Aya, tosha. Aya, let's wake up. Aya, kidogo, kidogo. Let's be together. Aya. Let's come back. Let me stay on that side. Haya, songeni karibu. Songeni karibu. Let's move closer. Haya, how was it? Chaotic, eh? Let me ask you a question. Wale first aiders, hebu tuinue, wale responders, tuinue mkono juu. Responders. Who was in charge? Did you see? No, you saw he was in charge. Why did you go, all of you, to the patients? What if the area was not safe for you? What if they had been attacked by pangas? Watu wamekuja wakakatakata na nyinyi mkaingia na wao ndani. What if? Did you think of that? Your safety? You didn't. Because you all went in. And anybody went to any patient that you felt like? Sindio? So in... let's keep the laughing. To laugh kama wale wazungu. Ile laugh basi, kidogo organized, ile kucheka. Kuna ile kucheka paka mwenye alafu postpone tacheka baadaye. Haya, sasa ile kijaribu kusema ni kwamba in a mass casualty incidents there's normally a lot of confusion. A lot. What if one of you guys had asked, wale wote wameumia njooni hapa? What could have happened? No, not all. Those injured. And that's a simple way to move people out of the area. And they could have walked. No, with that, you are simply doing triaging. All the walking wounded will come to you. Then you'll remain with the patients who are down to be seen and attended to and tagged differently. So when it's a mass casualty incident, when patients are tagged, most of you would have concentrated with a patient who's not even a patient. Because in a mass casualty incidents, not everybody is a patient. Hapo kuna waizi ndani, kuna nani, kuna kila mtu hapo, si ndio? So you need to have, maybe in your facility also, because when they came in, I'm very sure you also handle one of your own ukidhani pia ni mgonjwa. Kweli urongo? Because again, they were not uniformed. Maybe in our facilities, you can also start. Kuna time kitambo, sitasema ni wapi. I went to a facility to assist in patient. There was a massive accident. Do you know what they did? They got papers, wakastick huku. Kuna mtu alikuwa akienda akiwa tag. So that when you come, you know who's the relative. Huyu ni staff. Sindio? Manake maybe you'll also need the cleaners to come in to assist to move patients. And maybe you don't know them. You could actually put them out. So maybe you can have uniform setup whereby when masses come in terms of patients, you have that. Sawa. And then triaging, musiwache waingie ndani ndo mwa triage. You can triage them from outside. You can have one person outside triaging them according to the case that they're in. Or even segment our facilities into the 4 zones. The 4 colors as they were here. Sindio? The greens, the yellows, the reds, and the diseased. So as patients come in, they're already sorted. So you handle them as per their injuries that they're in. Then you allocate them the management that is needed. Any question? Any question? So, no shanga.
20 minutes.
Thank you so much. Let's move over.
We need to clap for the one.
So I told you
This is the second last station. This is the second last station. Kenyan. The station onto my right corner is ECG, cervical cancer screening needs to be, mass trauma management, care of the dying patient, and diabetic foot exam. Let's have some people in the diabetic foot exam. Let's settle down.
Sorry.
The diabetic foot exam at the center. Remember, this is your second last station.
Okay, Assalamu alaikum wa rahmatullahi wa barakatuh. MashaAllah. Okay, our time starts now. Mwana City will start. ICU nurse. MashaAllah. Then Mombasa chaplain Dr. Khatib atatueleza process, and then inshallah we'll summarize. So
You want me to start? Assalamu alaikum wa rahmatullahi wa barakatuh. As I said, my name is Mwana City Ali. I work in Coast General. In Coast General, we have 2 ICUs. Currently, medical, surgical. In my ICU, we have 4 Muslim nurses. Alhamdulillah, for the doctors, I think we have 6. Among the 6, just 1. The 5 doctors are all Muslims, alhamdulillah. We are doing quite well. Despite a few challenges here and there. One of the challenges that I'm facing in ICU, so many relatives coming to visit the sick. So many relatives. And then we restrict, let's have a maximum of 3, only to see that maybe the whole family has come to visit the patient. So it's tricky for us, because thinking of the hospital-acquired infections, we educate them, lakini we are facing challenges. So please help us spread the message to the society. And then I usually think of the Islam aspect. Somebody comes to visit the sick. Somebody comes at, let's say, 1. They visit the sick. Maybe a whole group, they want to stay there until 4. Askari comes to remove them, lakini watu wataki kwenda. So I think Sheikh will clarify kama I'm right, kwamba you go visit a patient, take the shortest time possible. Sinivo, make dua, let's go. Or if possible, let's stay at home, especially as the female. Let's stay at home, very few to come see the patient. Let's make dua for them. Na bi'idhnillah, Allah will accept our duas. Another challenge that I'm facing there, when a patient passes on, issues of privacy. Okay, even before they die, it's a general ICU. For both, we admit 5 years and above. 5 years and above, it's a general ICU. We only partition by curtains. So at times that we have a Muslim patient, nakwambia mimi, I want to be nursed by a female nurse. At times, although I try to balance. Within a shift, we have female nurses and male nurses. So at times, it's a challenge, but actually we try. Another challenge, as I said, when a patient passes on, because the majority of my colleagues are Christians. To our colleagues, when a patient passes on, it's like kila kitu imeisha. So they can do anything with the body. So when I came to realize kwamba even at that particular moment, kuna ile dignity, kwamba you have to preserve dignity. So I'm trying at my level. I educate my colleagues because I have a lot of challenges. So I try to educate my colleagues, and alhamdulillah, we're making some progress. Yeah.
Bismillah. As I said, let us remember, usimwache yule kwenye sakarati peke yake bana, tafadhali. Tumezungumza na tunarudia, kuna mambo matano bana. Hiyo ni haki yake na ni haki yako wewe. Leo ni yeye, kesho ni mimi au ni wewe, utakuwa katika hali hiyo. Hakuna njia, hakuna ujanja wa kukimbia hiyo siku. So mfanyie haki yake, kesho na wewe utapata mwenzako atakufanyia hiyo haki yako hapo. Na kwanza tumezungumza talqin, la ilaha illallah, kwa sauti mzuri, sauti ya chini. Usimpigie kelele yule hayuko katika hali ya kawaida. Hata ukampigia kelele ikiwa si wa kusikia, hatosikia. Zungumza naye pole pole, la ilaha illallah, la ilaha illallah. Inshallah Mwenyezi Mungu ampe taufiki azungumze hilo neno liwe ni last word katika maisha yake. na Mtume asema atakai kuwa last word yake ni la ilaha illallah dakhala aljanna. Hata kama amefanya nini, masahaba walimuuliza hata kama amefanya nini, akaambia hata kama amefanya nini. So usimnyime ile wakati huo. First. Second, direction ya kibla. Kama vile tulivyoeleza, ikiwa utamweka hivi, ikiwa kibla ni huko utamweka hivi kama anavyowekwa maiti, utamlaza kwa ubavu wake huu wa right side, au utamwekea miguu huko, uso wake unatizama huko, akifa awe anaangalia kibla, kwa sababu imethubutu katika hadithi za Mtume kwamba kuna sahaba alihusia akifa akiwa yuko katika sakarati al-maut alekezwe kibla. Mtume akaelezwa yule sahaba amehusia hivi, akasema amechagua umbile lema, umbile zuri. Kwa hivyo ni uzuri Muislamu akifa awe amelekea katika upande wa kibla, direction ya kibla. Ikiwa ni huko kibla, ikiwa ni huko utamlekeza ule mtu wako. Ya tatu, third, ni surati Yasin. Tumeeleza, tunarudia. Mtume asema hii surati Yasin inafanya roho itoke kwa taratibu, kwa polepole, kama drop ya maji ile inavyotiririka katika gata. Polepole malaika wanachukua kwa ile wanashitati nashta, kwa polepole, kwa huruma, huku wanakuambia maneno mazuri, huku wanakubembeleza huko. Na Mungu tujalie katika watu hao. Amin. Kisha hayo ni matatu wakati ule katika period ya sakarati. Ya nne, kiwa ushahakikisha ule mwenzako asha kufa, fumbe macho, jaribu ufunike mdomo wake ikiwa wazi, kwa sababu Mtume anasema wakati ule roho ikitoka, macho yanafuata roho. Tunatizama, anatoa macho kwa nguvu sana, na pengine na kama na mdomo unafunguka. So hata ikiwa mtu unaona mdomo wake haukai vizuri, hautaki kufungika, hata unaweza kufunga nguvu kwa ziwa. Hiyo kisha ya mwisho kabisa inakuwa ni baada ya kumfunga unamfinika nguo mwili mzima. Kisha sasa inakuja process nyingine sasa, zile za kuosha, za kukafini, za kuswalia na za kuzika. Na zote hizo Mtume anatuambia amrul mu'mini kulluhu khair. Paka mwisho, yani unatiwa manukato, unaoshwa tena, unaoshwa lile kule manake kuosha ni aina mbalimbali. Lile kuoga mtu katika kuogeshwa, manake maiti anaogeshwa, haogi yeye, lakini anatiwa na manukato anachukuliwa mrembo, yani anapelekwa, na inshallah urembo ule iwe ni njia yake ya kheri pia ya mwisho wa umri wake. Sasa ni hayo muhimu madaktari, manase, ambao kwamba mara nyingi hizi situation kama hizi nawapitia bwana. Ukiwa na ndugu yako, dada yako pale, na wewe ukiwa uko busy, huna wakati huo, tafuta mtu, si lazima wewe. Tafuta mtu bwana mfanyie talqini huyo, au some surati Yasin, au yule anaingia bwana, taja mema ya yule, kwa sababu malaika wako karibu na wanasema amin. Unayoyasema mazuri wanasema amin, na dua ya malaika ni makbul, ni mustajaba. Siwache watu kukaa na babaraza ya kijinga hapo, si pahali pa ujinga hapo ni pahali pa wakati huo ndio hata yati kali yaqin. Hakuna hakika kama hakika ya mauti, japokuwa sote lakad kunta fi ghaflatin min hadha. Hivi sasa mtu kutajiwa, unajiona bado kwa sababu unasimama kwa miguu yako, unakwenda, unajiona una nguvu, hutaki kusikia, unajaribu kuignore hiyo maneno, lakini itakuja. Wajaat hata Mungu anasema wajaat, itakujia wewe, hakuna ujanja. Wenda ukaingie wapi, ufanye ujanja wapi, kuna siku yako itakuja, na sote tutapitiwa katika hali kama hiyo. Sasa inshallah Mwenyezi Mungu atujalieni katika watu wema, tupokewe na malaika wazuri inshallah, tuwe katika watu wema inshallah. Na natarajia Sheikh.
Naam. I think Dr. Khatib ameeleza yote ile muhimu. A difference between Khatib na mimi ni kwamba yeye yuko Mombasa ambayo which is a majority Muslim area. Mimi niko Nairobi which is a lot of us are reverts, or maybe our parents or new reverts who are coming to Islam. I think basically when a person dies, yeye ameeleza hiyo process yote, but now mimi naeleza ile process nyingine hospitali. When a person dies, families are divided into two. Kuna wale ambao ni Waislamu asli, they know the process, watakuja, wataklia mtu wao, watamuosha, anazikwa Kariokoo ama Lang'ata. On the other hand, kuna sasa jamaa zetu wale ambao they are reverts, new Muslims, who are the majority. So mostly unakuta pale ndio inakuwa importance ya chaplaincy, whereby you as a chaplain unawasaidia kuclear ile body, unawasaidia pale Kenyatta tuko na mali ya kuosha ile maiti, kwa hivyo tunawaoshea, and then tunawakafania, tuko na pale Nissan tunawapelekea kaburini na tunawazikia. So most of our services, especially to the new Muslims or to the Nairobians, is usually free. Naona like 90% usually they don't pay. Even some, even we go extra mile whereby if they are poor or maybe mtu alislimu akatupwa na watu wake, so we have to pay for their hospital bill. So mostly unakutaga tu tuko michango, na alhamdulillah Nairobi is a big city and people are very generous, alhamdulillah, especially ikifika mambo za vifo wanatoa dakika moja na tunazika. Alhamdulillah. Also the good side of the KNH hospital, mara mingi wanasamehe deni. The other day there was a Muslim who owed the hospital 2 million, alisamehewa. The other day there was a Muslim alikuwa anadaiwa 800,000, alisamehewa. There was a Muslim social work inafanya kazi mzuri. These are some of the positives about KNH. Huwezi sikia mali ingine, but hii hospitali inasamehe madeni sana. Inasamehe madeni nyingi sana, you know. Even sometimes tunaona haya like kwani tutasamehewa kila kitu, si hata basi tumchangie aweze kutoka. Biggest challenge pale also ni kwamba Islam is growing very fast in Nairobi, outside Mombasa, outside Northeastern. It's very fast, like forest fire. How do you know that? Pale mochari, mimi mwenyewe nakuta mtu anakufa. I didn't know they were Muslims, but he was a Muslim. Akifa sasa unakuta families are divided into two. Kuna familia yake ambayo ni Waislamu wanasema he was a Muslim, they want to bury him as a Muslim. Kuna familia yake wanakuwa Wakristo, wanasema azikwe Kikristo. So kuna mvutano sana ya maiti daily. And then kuna sasa issue ya kutransfer maiti. Wajaluo, Wakisii, Waluya sana they deeply wanataka wapeleke maiti zao ushago. And the reason also is because burying in Nairobi is very expensive. 18,000, you need to have 18K to bury. Kariokoo, Lang'ata, I think it could be more expensive. So those are the main challenges that we have. Me, what I've seen which is very bad ni kwamba Waislamu tumekuwa kama wale wasiokuwa Waislamu. Mtu anakaa ward for many days. Siku ile anakufa, mtu atatoka Lamu na Malindi na Garissa na Wajir na huko atikuja kufanyaje? Kupigania maiti. Yani Muslims were exactly like non-Muslims. Ndio hata ICU nasa anasema kweli kama ulikuwa unapenda huyo mtu ungekuja akiwa hai, lakini sasa ile anakufa, everybody becomes emotional na hivi na vile. So I think this is the worst failure on the Muslim side. I think last of all ni kwamba you as medics you have a role to play na because chaplains hawatakuwa kila mahali, hawatakuwa na patients, sometimes you go off, sometimes usiku hatuko. I think nyinyi ndio mnafaa kubeba hiyo masulia ya kuwakumbusha la ilaha illallah. Uko na kwa simu yako suratul Yasin, mwekea asikie. Unaona mathalu kalimatin tayyiba kashajaratin tayyiba, sio? Inshallah ule anakufa mwambie inshallah anta min ahlil janna. Unaona, muombe dua. Unaona, na pale kuna malaika 70,000, sio? Unapotembelea mgonjwa 70,000 angels. wanasema amin na wanakuombea msamaha, sio? Na kuna wale malaika wa kutoa sakarati. So there are so many angels and your duas are accepted. So you have major responsibility than us as sheikhs. I think kuna 2-3 minutes ya comments au maswali. Yes. Yes. Naam. Yes. Yes, it's a good question, yeah. The ones who are supposed to? Yeah, yeah. Okay. Yes, to bury them as quick as possible, yeah. Okay. Yeah. Number one, we are, as a senior chaplain at my office level, we've written to Kenyatta tuondolee hiyo mambo ya Waislamu kupelekwa mochari. Even tuko tayari kwamba tulipe fee mochari which is 5K and then tupewe maiti yetu bila kwenda mochari. Inshallah hospitali itakubali. Niko katika hospital ethics committee and these are some of the issues that I've raised there. In terms of kuklia maiti Kenyatta, tume advocate na sahi kuna ule mtu wa malipo wa finance wa bill. Pale mochari yuko tumeletewa. So Waislamu mtu akifa unaenda pale mochari, kama ni NHIF cash unalipa pale mochari na the process is smoothened. But as for hiyo protocol ya mochari na nini, it's still an issue. But inshallah in like 3 months inshallah tutakuwa tumemaliza na we are lobbying for that, at least watuondolee hiyo. Yes. Yes. Yes.
Around
3 p.m.
Sasa hiyo time ya kuclear hiyo bill kuchukua maiti yako ende nayo imechukua hata yani imeenda ni sisi tushasema tutamtoa maiti. Unajua Waislamu watuweke so hiyo time ya kuzunguka kwenda billing, waenda billing hakuna mtu wa billing, sijui saa hii ni usiku mpaka saa 2 aje. Watoka hapo billing waambua sijui mpaka uende kwa records, sijui mpaka daktari akuandikie permit, burial permit. Tukitoka pale ikabidi tuhairishe ile ya dhuhuri tuweke alasiri. Tukitoka pale Makadara it almost saa 7. So kama saa 7 mchana, kwanza alikufa tatia usiku. Hiyo process sasa mara wenda huku, mara wenda huku. Anapetewa ama staff na nimepata hiyo shida. So wale ambao si staff wanasafa vipi? Mpaka tukaambiwa huyu maiti haisi kukaa hapa ward, tunapeleka mochari. Nikamwambia sasa mimi nitafanya nini na sasa tutakilia vipi hii bill? Tukaambiwa kule mochari kuna upande wa Waislamu wanawekwa. So imagine huyu amekuja kubeba hiyo maiti, he's not a Muslim. Na nikamwambia my brothers wa Kammp, akamwambia nyinyi nendeni, tushamweka label na kuna tag, hatujui